Good afternoon, everyone. It's almost 2 o'clock here, and I think I'm going to go ahead and get started in our next session this afternoon.
Well, how are you?
I've got actually one question that maybe we can answer before we get it rolling.
Oh, sure.
I've got someone who asked, does the doctor or specialty nurse have to be present in the room for the entire conversation with the patient for billing purposes?
For billing,
billing purposes. For an advanced or planning
Consult.
Yeah. Right. Howdy. So for billing purposes, you know, that is a good question, because the people who are billing it are the nurse practitioner, the CNS, the physician. So it depends on that delegation, I guess. If you're doing it in the office or in the setting, I think that if they're going to be billing for it, they need to be documenting for it.
The QH, the individual quality, the healthcare, qualified healthcare professional needs to be involved in the 30 minutes. Yes.
That's not to say, when I would do a family meeting and we were talking about some of those things, then I would bill my 30 minutes of the family meeting. Whereas in the past, I could not bill that because I did not lay hands on the individual. So.
But you only bill if you're involved for the full 30 minutes.
Exactly.
If you're not there for the full 30 minutes, either somebody else bills or you don't bill for that segment.
Right.
I think that's the question.
Okay.
Did that answer the question, Matt?
I think so. Thanks very much.
Good question, though. I think we're still, you know, in the infancy of using those 2 CPT codes for advanced care planning. I know in the outpatient setting, ambulatory setting, it's probably being used a whole lot more than it is on the inpatient setting. So I can only imagine that as more people try it and document it and then submit billing for it, then we'll see how effective it can be. So anyways, good question. I'll go ahead and get started with this last session, which I titled Meaningful Goals of Care Conversations in Acute Care Settings. That was, as we were preparing for these sessions, we really talked about how important it was to share with everyone how those goals of care conversations can occur in acute care settings, but also how different they might look. Even though the principles are very similar, the concepts are very similar, they really might be different because we're in a different setting and we're facing different situations. Well, let me introduce myself. I'm Maria Fox, and I am currently, and this is a fairly new role for me, I'm a director of advanced practice providers at the University of Kansas Health System. But for the last 6.5 years, I was so fortunate to be on the palliative care team at the University of Kansas Hospital with Dr. Karen Porter-Williamson, which you'll be hearing in another session in the future. I'm also fortunate to be associated with the Center for Practical Bioethics as a clinical ethics associate here. So I like to spread my wings a little bit and I do dabble in ethics. I shouldn't say dabble, I actually do seriously work with ethics with medical students, nursing students, advanced practice providers as well. So let me tell you a little bit about my practice. Currently, I'm in a management role, but before that, I can tell you honestly that almost my entire career was in critical care settings. As a clinical nurse specialist, as an educator, I was a manager, director in ICU settings, almost exclusively. So my background comes from that. And along the way, I realized that we could care for our patients so much better because, as you might know or can imagine, that we have so much technology and advanced treatment options for our patients in hospital settings and acute care settings and ICU settings. And so we can put them in place, but a lot of times we had to ask ourselves, should we? Were we, and this is a question I asked myself many years ago when I started down this path, you know, were we using these treatment options to prolong life, or were we using them to prolong death? And so that's a question that still comes up from time to time. Let me advance the slides here. Okay, here we go. So a few things that I'm going to try and accomplish this afternoon is differentiate how the goals of care conversations occur in acute care settings and how they're different from the other settings, the long-term care settings, the long-term resident settings. I also want to make sure that I get to give you some strategies to guide the goals of care conversations that you might have in those acute care settings or ICU settings, and really, in essence, primarily adopt those primary palliative care principles to have those goals of care conversations. So allow me, so I'm begging you to allow me some indulgences here, because I am going to get somewhat basic with you on some of the terms and concepts. So it's really surprising still to me that we still struggle with knowing what's the difference between hospice, palliative care, end of life, and so many of us use them interchangeably. So I do want to share with you that we're trying to evolve the understanding a little bit more. And so this slide here, I've adapted it somewhat, but I want to use it to help you understand when we're using these words, what they do mean. So hospice really is a model of care delivery for end-of-life care. It's a Medicare benefit. And it utilizes an interdisciplinary team of physicians, nurses, advanced practice folks, social workers, chaplains. It's a well-developed concept. And Medicare benefits say, we're going to pay for these benefits, especially if, a physician can document that a person, if they would go along their usual trajectory of illness, would have 6 months or less to live. So you sit there and you go, wow, this is a great benefit that someone who is facing their end of life after chronic illnesses or in a terminal state could benefit. Yet we see the median use of hospice at about 14, sometimes 17 days. You'll see some studies that show maybe a little bit more. That's only a couple weeks or so, not a whole length of time or the 6 months benefit that Medicare says we can get. So keep that in mind. That's hospice. It's a specific model of care delivery. Now, palliative care is a broader concept. It's actually a philosophy of care utilizing the same model, the same interdisciplinary model, which includes physicians, nurses, advanced practice folks. It includes social workers, chaplains, pharmacists are really getting into the palliative care world of philosophy. But this philosophy of care is actually aimed at patients who have critical illnesses or might be at high risk of dying. But notice how broad and comprehensive it can be. And this isn't drawn to scale, but it certainly is to give you the idea that palliative care is that much broader concept. And then we have those groups of people that really are at end of life. Those are the ones that, because of their illness trajectory or lack of treatment options or by choices, they're entering into their final phase of life. Now, all patients who are benefiting from hospice are also benefiting from that palliative care philosophy, but not all patients who are at end of life are benefiting from hospice use. And we hope to think as we move the envelope, as we push the envelope on caring for patients in acute care setting, that we start to embrace these palliative care principles for all patients who are critically ill. And in fact, this is my 30-second elevator pitch. I think many of you have been asked to think about what your 30-second elevator pitch would be on what you would do. So what is palliative care? And we kind of revolve it around these three main concepts. It's expert pain and symptom management to relieve suffering. And I think all of you are probably nodding your head going, gosh, I do that too in whatever setting you practice. It's also about communication or counseling around difficult issues, difficult conversations, but it's patient and family centered, especially around those goals of care. And I believe many of you are also nodding your head going, gosh, I do that as well, or that's part of what I hope to be doing, you know, as I'm working with patients and families. And the third thing is really to assist with those dispositions or transitions out of the hospital or out of whatever setting into the more appropriate setting. Sometimes it is home with hospice, sometimes it's to the next rehab facility, sometimes it's to long-term acute care, or sometimes it's to long-term care or SNF settings. But whatever it is, we're doing all those things. So when you think about that, you know, a lot of you are already doing some of that palliative care. It really is about providing the best quality of care for patients who are seriously ill and at high risk of dying. And those are some definitions that have been evolving over time. So I do want to show you this. This is probably something you've seen this before, this diagram. It's a traditional paradigm of how we used to use palliative care in hospice, and maybe in some settings it's still being viewed this way, where a patient will be going through a lengthy course of curative treatments. It might be for cancer treatments, it might be for other diseases, but you can see that all the intents of the treatments are to cure that patient, or to actually, you know, obviously in a broader sense, to make that patient better. But then we come to a hard stop and we say, gosh, we don't have any more treatments to offer, so bam, we've got to move them into this palliative care scenario. And then when that doesn't work anymore, or those options aren't available, now we've got to do hospice. So it really was kind of that, you know, that hard stop kind of scenario that we would have for our patients and families. But what we want to do is actually make sure you're aware of this new paradigm. And I've taken this from the University of Michigan geriatric program because it really does, I think, demonstrate a little bit better as to where we are in some of our treatments. As you can see, there's a phase, that initial phase, where the patient is healthy. And so all the treatments we have are aimed at preventing any illnesses for the patient. But gosh darn, there's that diagnosis that happens. Maybe it's a cancer diagnosis, maybe it's kidney failure diagnosis, or liver failure, or COPD, any one of those things. And so you enter a phase where palliative care might be appropriate, because remember, with palliative care, we're doing some pain and symptom management. And throughout that course, you're also doing some curative or life-prolonging care. At some points, you might be doing a little more palliative care because maybe the patient's needing more symptom management. At other points, maybe, you know, symptoms are well managed, well controlled, and, you know, the treatments for the prolonging care or even the curative intent is there. But as you can tell over time, as a patient's condition declines or the disease becomes more progressive or starts to reach into those end stages, that's when we start to see more of those palliative care principles included, especially when we think about those conversations about life closure. And even as Dr. Carol Buller was talking about, maybe having those conversations about future options around treatments and end of life and dying. And then, of course, making sure that we engage our hospice benefit there. And because hospice has the benefit of even extending beyond that dying phase to support family with bereavement and grief support. So I like that diagram very well, and I think you're more than welcome, as I gave you the source, to use this when you're educating others in your facility or setting, as well as your patients and families. Palliative care really got, you know, a lot of evidence behind it back in 2010 when there was a randomized control trial of palliative care interventions for patients who had non-small cell lung cancer. And those people that received those palliative care interventions, which included the multidisciplinary interventions, the goals of care, the talking about the what ifs, and really what was important to them, which included the pain and symptom management, compared to a group of patients who really just received the usual care. Those patients who received the interventions actually lived a little bit longer. They also had less aggressive treatments, which for many of us might be an okay thing, especially if we're accepting that non-small cell lung CA is going to be the way someone dies. But we also showed that those patients had better documentation of their preferences. And in the end, we really want to make sure that we cover that as well. So what does this have to do with the intensive care unit or acute care settings? Well, that first comment there just really strikes me every time I see it. And it still holds. This is probably a comment, a statement, a statistics that I saw probably about 10 years ago or so. And every so often I go to the critical care internet sites to see has that changed a little bit. I think John gave you some statistics earlier. So it really is profound to say that 1 in 5 Americans will die in or around an ICU stay. Imagine that 1 in 5 Americans will be dying either in an ICU or right after an ICU stay, especially when there's been artificial life support involved. Other statistics, nearly 60% of hospital deaths occur in the ICU. That to me is profound as well. And there was that period where we would continue to fill ICU rooms. Many days we didn't have ICU beds available. And imagine that 60% of those people in the hospital were dying. I'm hearing some feedback from some folks, so if people can just their computers, thank you. So a high rate of death occurring in the ICUs. That, you know, compare that with 80% of folks saying that they want to die at home. And you've heard that, you know, in a couple of sessions, that a large percentage of people, when asked, say, gosh, I really would like to die at home in my own setting. You know, for me, you know, surrounded, you know, with the people that I love. I even talk about, you know, my little precious dog being with me at my bedside. That's how I picture how I want to die. And even though we're getting better at documenting our advanced care planning conversations, it really still isn't where we want it to be. You know, about 25 to 30% have documented those advanced care planning conversations with the forms that you've heard of. So we have a large group of patients at high risk of dying in our ICU, or at least of having complications and having serious illnesses. So this strikes us in the ICU world because there are actually 2 types of illness trajectories we see. And the first one I illustrated for you by that roller coaster. And you've probably seen this in terms of many of the patients you see in the ICU. We do all kinds of interventions for them. We even put them on ventilators and use vasopressors and use all sorts of interventions, and we stabilize them. And there might even be a point where they get better, and the families hear words from the different consultants and the different physicians. Well, he's getting better. His kidneys are better. His lungs are better. I think we can get him better. And so the families have this hope buildup that, gosh, their loved one who was so sick in the ICU is getting better, is going to get back to where they were before. But gosh, now we have a new infection. You know, being in an ICU can be really dangerous for patients, especially with all the interventions we do have for them. We're so intent on preventing infections, yet there's a high likelihood that they're going to get infections from their central line, maybe from a ventilator, mechanical ventilator, because there's a tube down their throat. Maybe, you know, because their perfusion is poor, that they're actually going to have some skin breakdown and even develop some wounds on their coccyx or limbs or any other pressure areas. So the families start to go through this roller coaster where one day, gosh, they're very hopeful, things are looking better, their oxygen saturation is better, but gosh darn it, the next day their blood gases aren't as good. And when we say this to families, you can just see the nods in their heads and you know, in their faces when they really do see this ICU trajectory. The other ICU trajectory is really described, or you can see this illustrated by this picture, is that, boy, they come in with some devastating injury or even illness where all we see is that downhill slide. There's no ability to even, you know, gain any ground with this, but all you see is just that downhill slide. And at the end, you don't know if they're going to crash and burn at the end. But two common ICU trajectories, and that's what we see a lot when we're dealing with the patients and families in acute care settings. So palliative care now in those settings gets consulted when usually there's nothing more to do, and you'll even hear that. You'll hear the attending physicians tell the patients or families, usually because patients might not be in a position to understand what's going on, that, well, there's nothing more to do. We're going to have to get the palliative care team on board. Or, you know, patients and families are asking to stop or withdraw or even withhold treatments, and the attending physician's not quite sure what to do at that point. You know, we've done all these aggressive measures, and remember, you know, the nephrologist just this morning said his kidneys are doing better, or the pulmonologist said his lungs are doing better, but boy, the family is asking us to either stop, withdraw, or even withhold treatments. Then there's also the issue or the situations with healthcare providers are demonstrating distress about the plan of care that's in place. Maybe we are going too far, as Dr. Biller illustrated with some of the patients and cases she had, you know, when conversations have happened already and patients are beyond the point where they've wanted to be in terms of machines and artificial life support and treatments, that now we're starting to worry, are we doing what this patient really wanted us to do? Or we've had maybe the ethics committee involved, or maybe another provider or consultant recognizes the very same thing, that maybe we shouldn't be starting dialysis on this elderly person. So palliative care gets consulted many times in those situations in an acute care setting. So this is what happens. Well, you know, the attending physician says, we're going to ask the palliative care team to come see your mom. And what reaction do you usually see from patients, from families, from physicians when you ask for this? And, you know, I don't know about you, but I love Lucy because of the facial features she would demonstrate. You could tell what she was thinking and feeling just by what was on her face. But I laugh at this because this is what we'll see from patients and families when they hear we're going to ask the palliative care team to come see you. You know, this one here is just total, utter shock and surprise, because nowhere in that patient's course of illness has anyone said, you know, gosh, we really need to sit down and have these conversations, right? You know, that roller coaster, it might be weeks of treatments, at least days, before we actually sit there and say, gosh, maybe we better have a goals of care conversation. You know, again, you know, that surprise look, you know, what? I heard the nephrologist say the kidneys were doing better this morning. Why would we need to get the palliative care team involved? And again, you know, it might be because there's misunderstanding about what the palliative care team can do. You know, how dare you bring that up? And maybe even some indifference, you know, well, it's just another consultant that's going to come in and maybe tell me the same thing over, or, you know, tell me there's nothing more to do, or, you know, tell me that what we're doing is not beneficial. So there really are some genuine reactions we need to be attending to when we bring up the word palliative care. And so we know that there are misconceptions about palliative care in acute care settings. We hear this often. This is a phrase I wish we could just X out of everybody's jargon, and maybe you've heard this. I know that even in the city, I did a little bit of work at a facility that I will not name right now, but going palliative was very common. And you know, we'd walk up to the patient or family or even the staff, and they'd see us come and go, gosh, I didn't realize he was going palliative. You know, Mr. Smith's going palliative. And I'd go, well, I'd ask, well, what does that mean to you, going palliative? Remember that first slide I showed you, palliative care is a philosophy of care. So what does going palliative mean? So I wish we could just erase this from everybody's jargon. Along with that, you know, when they see us come up to the floor and I say, well, I'm here to see Mr. Smith, I'm from the palliative care team, somebody will go, well, I didn't know he was dying. Again, you know, that's a misconception. Palliative care is not about somebody dying. It's about other things. It's about that pain and symptom management, that goals of care conversations. Two, they think about palliative care as that's, you know, that's the people that are going to ask us to withdraw or stop care. You know, again, that's a misconception about what palliative care is. And then they'll see us come and they'll see us on board, but you know, they'll have a full code status, and the question is, well, if they've got palliative care, why aren't they a DNAR, but do not resuscitate? Again, another misconception about palliative care. And even when we say to patients and families, well, you know, I'm Maria Fox, I'm here from the palliative care team, and your attending physician asked me to stop by and meet with you and see how we can be helpful. The first comments many times from patients and families are, well, I'm not ready for hospice. Again, another misconception about palliative care. And worse yet, as you can imagine, you know, there's the death panel notion, you know, that we're getting palliative care here. That means there's nothing more to do. That means we've got to prepare for death. And as I mentioned with that first slide, it isn't always about dying, but it is about having meaningful goals of care conversation for patients who have those serious illnesses. And again, this misconception wanted to emphasize the point that palliative care is the same as hospice. That is a major misconception out there. And hopefully with this seminar, with this session here, you will go out there yourself and start reading a little bit more about palliative care or asking questions within your own facility as to how palliative care is perceived. I do want to show you a couple of models of palliative care in the ICU that's really has been around for a little bit, but also that we're continuing to evolve. And the first one is that consultative model. And maybe this is familiar to you in your own acute care setting or hospital, where you'll see that, you know, there's some patients that are cared for in the ICU by the critical care team. They receive the usual ICU care. And then, but they consult the palliative care team. So you'll have a group, and I guess I should check and see, oh, here we go. Sorry, I wasn't using my pointer. That you'll have a group of patients that are benefiting from that palliative care team as well as getting that usual ICU care by the critical care team. And then you'll see that there's a group of patients that really are benefiting mostly from palliative care. They're not really in that usual ICU care. So that's one model of care. And as you see by my cartoon, I think you'll see where my bias is, because the physician is telling the person there, you know, there's no easy way I can tell you this, so I'm going to send you to someone who can. And a lot of times it feels like that, you know, that there's something bad I'm going to have to tell the patient or family. Or there's, oh gosh, there's some treatment options that I'm worried I'm going to have to bring up. Or, you know, worse yet, the bad news that has to be given to the patient and family. And I don't feel comfortable. I don't want to say that. I don't know how to say that. So let's get the palliative care team in. So that's one model. And the other model is one that I'm really biased to. And again, to remind you that my background has been in ICU care, and really over the last 6 years or so, really delved into that palliative care world. And what I've known is that a lot of those palliative care principles or interventions can be embedded in our usual ICU care. If we educate our nurses, our physicians, our advanced practice providers, and even our patients and families to say, gosh, you know, all of those palliative care principles, and remember what they were in that 30-second elevator speech. There were that pain and symptom management. That was that goals of care conversation that's patient and family centered, as well as the assistance with transitions along, you know, the trajectory of whatever it was, the hospitalization or even the decisions about disposition. That if we can include all of those in our usual ICU care, that's that integrative model. So I'm hoping to see more and more of that in our ICU settings. And indeed, there's a lot of research, a lot of evidence that's gaining in the ICU world about doing just that very thing. And in fact, a lot of fellows in ICU critical care fellowships, physicians, those are physician fellows, as well as nurses, are getting training in some of those palliative care principles. So going back to those palliative care principles, we start to call them those primary palliative care principles. Again, the pain and symptom management, the conversations and informations about conditions and anticipated course of illness. We know those things, especially in terms of those ICU acute care settings. But there's also the breaking the bad news. We know there's going to be times when we have to tell patients and families that, gosh, this aggressive treatment that we've been implementing for the last few days, i.e., whether that's the mechanical ventilator or the dialysis, it's not helping. And in fact, it might be making your mom, your dad, worse. And so that's breaking bad news. And so we've got to be good at using our communication skills in the acute care settings for everyone to do this. There's also the need to do that consensus building. You know, in an ICU setting, you have a patient who has multiple comorbidities. And so in order to give the best care possible, many times we bring in all those consultants. And as I've been reflecting on some of the conversations or comments that patients or families might hear on a daily basis, for example, from one consultant, like the nephrologist, and I don't mean to keep you know, picking on the nephrologist or the pulmonologist, but those are commonly what we hear. You know, the nephrologist will tell the patients and families, gosh, those kidneys are doing better today, and yet the patient's still not responsive. And yet we still have the patient on 3 vasopressors just to keep that blood pressure at a minimum of systolic of 90/40 or whatever. So we really need to start to do some consensus building amongst all the consultants and providers. And then we need to really think about what are those realistic treatment options. And all of those take place with that goals of care and advanced care planning. Now, Dr. Bullard did an excellent session on doing this in the long-term care setting. And if you didn't get the nuance of what she was saying, it really is discussions that can happen over time, conversations that happen repeatedly even, and maybe even with or without family members, and with or without in family meetings, settings. In the acute care setting and with serious illnesses, some of these conversations have to happen in a matter of hours, in a matter of days. We don't have that time, and so it really is important to build those skills and have those primary palliative care principles in your back pocket. And along with that, you do have to have that inkling of the prognosis. You know, is this patient, even with all the treatments that we're applying, whether they're aggressive, maybe limited in some sense, am I able to say, gosh, with some level of confidence that this patient is going to do better, that maybe they'll stabilize at some point, or that they're doing worse? I mean, those are those kinds of thoughts and conversations you have to have within you and your team as you're caring for patients in these acute care settings or ICU settings. So just some initial work that's been done with utilizing primary palliative care principles, and I'll direct you to Dr. Mosenthal oh, and I forget, she does some work, I believe it's in New York, but she published early on in 2006 some work she was doing about doing those very things, you know, addressing the pain and symptom management, having those goals of care conversations for treatment preferences, and then having a family meeting very shortly after admission to an ICU by 72 hours, and then looking at outcomes. And she was doing this, you know, 10 years ago and continues to do the work around this in ICU settings. And what we know from that work is that really, although there's no differences in those do not attempt resuscitation orders or rates of limitation, what she saw was that artificial life support might, and discussions about stopping artificial life support actually was happening earlier, and that reflected in those shorter length of stays in the ICU and hospital. And a lot of times, remember back to the comments that I said, most people don't want to die in the hospital. A lot of people don't want to be in the ICUs, and ICUs aren't good places to be, especially if you want to not be there should you be really, really sick. The other thing is that people were addressing, the providers were addressing pain and symptom management so that there was better management of both. And in fact, out of a lot of that work, as well as Judy Nelson's work, there is a checklist available, and you know, if you go to the website for the Center to Advance Palliative Care, CAPC, or even look up the VHA Care and Communication Bundle, and you can just Google that, and I gave you a website here, the quality measures at ahrq.gov. There is such a thing as a palliative care bundle. And in the ICUs, if you work at all in the ICUs, we're great on bundles, right? We've got the sepsis bundle, we've got the CLABSI bundle, we've got the vent bundles, and so why wouldn't there be a palliative care bundle? And as you can see on day one, it really is about those important things such as identifying a medical decision maker, making sure that you know what that patient's advance directive is, or whether there was any conversations with patients or families, and really make sure you address what is the preferences around cardiopulmonary resuscitation. Distribute family information if you have such on those kinds of things, and then making sure we're assessing pain and managing pain. And all those things need to happen within that first day of admission into acute care or ICU setting. Now, by day 3 and by day 5, and actually I'll be honest with you, some of the more recent iterations of this palliative care bundle has compressed that even more, so that usually by day 2, we're making sure that social work is in place, that we've got spiritual support in place, and that, as you saw with Dr. Mosenthal's studies, that by 72 hours there was an interdisciplinary family meeting. So again, the concept being that we have these conversations and we have these in a more formalized way sooner rather than later because of the serious illness that these patients are having in the ICU setting. So to the family meeting, I know Dr. Bowler talked about that in her settings, in a long-term care setting, to have it over time, to include family members, to include maybe other providers who might have a contribution. In the ICU setting, you know, gosh, is it a nicety or a necessity? I ask the question because it really has been that, you know, sometimes we don't think about that family meeting until we make that consult, or we put in that referral to the experts, the palliative care team, or we call an ethics consult, you know, because a lot of times in the ICU settings, our physicians and nurses might not have the skills or even the confidence to have those family meetings. So really, you know, in the past, we've really been more reactive to those family meetings. Usually it's because there was a family crisis. You know, you have the daughter that comes in from the coast, you know, and hasn't seen dad for 10 years, and all of a sudden dad's really, really sick on artificial life support, and you know, the doctors are saying we really don't know what other treatment options there are. Or, you know, we're reacting to a family member saying, gosh, mom never wanted to be on a mechanical ventilation, and oh darn it, we've been doing this now for a couple of weeks. So, you know, we really want to go away from that reactive need to have a family meeting to one where we're proactive. And that's where all the research in the ICU literature is pointing. We need to think about family meetings more of that on that prophylactic basis, or really that routine basis, whether it's within the 3 days or the 5 days length of stay. We need to think about that for any of those patients who've been in those ICUs for long lengths of stay. You know, now we've had dad in the ICU for the last couple weeks, and gosh, we can't seem to get those medications quite right, or he's just getting sicker and sicker, and we're worried. We're worried that after a couple of weeks in the ICU, he's just not getting better. Or we're realizing that this illness is more serious than we thought. Maybe there's major procedures that are being offered. You know, sometimes, you know, a gallbladder, which might seem minor, now is accompanied by a patient who's on a mechanical ventilator and is needing blood pressure support from 3 different medications. And all of a sudden, a gallbladder procedure, which really is minor in a lot of instances, might be one of those major procedures, and the surgeon's having doubts about even taking the loved one to surgery. And maybe there's been even some comments made outside of the patient's room about, gosh, this just isn't looking good for Mr. Smith. There's a poor prognosis that we're worried about. Or even we can't find that healthcare person, the healthcare agent, the surrogate, the proxy, or even, yes, Mr. Smith said, you know, that his daughter would always make decisions for her, but gosh, she's out of the country. She's, you know, we can't find her. She's moved around 3 different times and no one's seen her for a while. So then again, now you're hearing my bias is that a family is really something that we really need to be thinking about as a proactive measure in ICU settings. I think I won't go into much about how a family meeting should be conducted. There's some really good information out there and some good mnemonics that can help you in terms of setting up a family meeting. But I really do want to just highlight some important bullet points, and it really is important to make sure people know why we're meeting, you know, and that everybody gets introduced. But we really need to know what's the purpose of the meeting. You know, are we just going to share information, or are we going to actually need to make a decision about some treatment options at the end of this family meeting? It really is important to glean from the patients and families, patients if you can, to understand what they know is going on with the patient's condition. You know, tell me what you understand is going on with your loved one's condition. What have you heard from the other consultants? It's really important to know that up front. It's your job to clarify, to educate, to answer questions. But what we do know in research about family meetings in the ICU, it's important to listen. It really is important to understand from families. Let them talk rather than us, the providers, going on and on about what's wrong with the patient. And then we really need to introduce the plan of care, which was held in a pre-meeting phase, because that's going to demonstrate that there is some sort of consensus around what is going on with a seriously ill person. There has to be consensus. It's going to be really hard to go into that family meeting and you're hearing for the first time that, oh gosh, there's a new treatment option or a new medication we can try. That really should have been discussed earlier on with the providers prior to going into a family meeting with family members. And then really there's the need to offer various plans of actions. And there's usually 2 or 3 options available, and I'll touch on that in a little bit. Briefly, I do want to tell you a little bit about my own doctoral research, but I had a case exemplar, and this was early on in my work with the palliative care team, where there was a patient who had been in the ICU already for a few weeks. He had a trach in place, he had a tube feeding in place, he was still able to respond and even communicate. Although he couldn't talk, he could write, he could, you know, we could lip read him, but he was able to communicate with us. And his wife was attentive by his bedside, but he was chronically, critically ill. And palliative care got consulted, and again, there's my bias. We got consulted about, you know, 3 weeks into the case, and the purpose for our consult was that we needed to help the patient and family transition to a long-term acute care, because that was in the plans. You know, the patient had a trach, he was not going to get off the ventilator anytime soon, so we had to help the wife make that transition. And you know, I talked with the nurse beforehand about the patient. The nurse was the one who had been with the patient, you know, and they usually are, they're the ones that are at the bedside for those 12-hour shifts or 24-hour shifts. But I also talked with the family and the physicians, and we had our family meeting. At the conclusion of the family meeting, the plan was to continue with the transfer to the long-term acute care. And I went back to the nurse and I said, gosh, you know, she couldn't join us in the family meeting because she was busy with her other patient. And I said, you know, this is the outcome of the family meeting, and that we're going to continue with a plan to move forward to the long-term acute care. And I will never forget, because that nurse is just an awesome nurse. She's an advanced practice nurse now, but she put her hands on her hips and she goes, that's not what he wants. And I said, what? And she said, no, he told me this morning he does not want to be on the ventilator any longer. He wants to go home and he wants to pass away peacefully. He wants to die. And so we didn't have that nurse in the family meeting. And so my doctoral research work was around what is that nurse's role in family meetings. So, you know, looking and exploring really from various nurses' perspective, you know, there are some important things that I always keep in mind about nurses, and that is those that have more experience feel more confident, and they feel competent to have these goals of care discussion with families, especially when they pick up on cues about what the patient or family had previously expressed. You know, did dad want to be on a ventilator for long term? This nurse in particular had had those meaningful conversations with the patients, and she knew that the patient did not want to go to a long-term acute care setting, did not want to be on a ventilator for very long, and in fact wanted to go home, get off that mechanical ventilator, and really pass away with hospice at home. So after we went back into a second family meeting, and this time the nurse was able to join us, we got that information from the patient. We went to the bedside as well, and he confirmed that for all of us. We were able to make a plan that night. Actually, we got hospice involved, and there was a very great hospice agencies in the community, but they were able to go along with a plan to have this patient get home. And once he was home, to get the mechanical ventilator off of him. Actually, he was bagged in the ambulance. Once he got home, there was no more bagging. They implemented comfort measures, and he passed away peacefully by the next morning at home, surrounded by his loved ones. So it really is important that we have the right providers in those family meetings. And really the other point that I gleaned from my research was that family meetings happen all the time. They just don't happen with the palliative care consultants. And so that brings me back to, in the ICU acute care settings, those of you who are there at the bedside, whether you're nurses or physicians or advanced practice people, or even social workers, chaplains, you are the ones that are having these conversations with patients who are very ill, or family, or their family members. You're the ones that are picking up on some of these comments and cues. So it is about our role in palliative care, and this is some of the more recent work that we're doing, is about coaching others in those ICU or acute care settings to provide that primary palliative care. And we've done it so far in our trauma ICU at KU. We're working on it to do, we're working on the very same kind of interventions with the heart failure team. The medical ICU team frequently asks one of our palliative care, or what they would like is one of our palliative care clinicians, nurses, or physicians to actually round with them as they're rounding on all their ill patients in the ICU. So it is about teaching others to now implement those primary palliative care principles, which again now includes having those goals of care discussions, because it really is important. There's that ethical obligation of providers to make sure that what you do present and provide as treatment options align with those patients' goals of care. Now, another diagram, this one's, I've adapted this one and I'm trying to work on it, but as you can see, when we think about an integrative model that includes palliative care and all those palliative care principles, we hope that all patients who have those kinds of needs in the ICU get these basic primary palliative care principles included, and that includes identifying the decision maker, knowing who the durable power attorneys are, making sure we focus on pain and symptom management, but that also as we go down this grid, that many of our patients, as their needs become more complex, that we start to include more of those primary palliative care principles, such as making sure our social workers are included, that we've got chaplain support and other disciplines, like our speech language pathologists who help us determine whether swallowing is going to be an issue, and maybe we need to start thinking about or bringing up the subject of artificial nutrition. So that by the bottom of this grid, as the complex needs are greater for these patients, that now we make that referral. So again, in broad summary, if more of you as providers, whether you're nurses, social workers, physicians, that you start to have those primary palliative care principles in place, that you go a long ways to meeting the needs of your patients and families when they are seriously ill. So there are 3 possible outcomes after these family meetings. One of them is that we continue all interventions, and a lot of times we need to address that CPR status, that code status. So, sometimes after these family meeting goals of care, we say, okay, we're going to continue these interventions, but we need to address whether the patient would want CPR or not. A second option is to continue these interventions, but if we see your loved one getting sicker, we're not going to add any more treatments. We don't escalate if that patient's getting sicker. In this situation, we really don't want to have that CPR as an option. We make sure that the DNR that is addressed, and we make sure that a physician's order is in place. Or another option after a family meeting is that at this point we're going to transition to comfort measures, we're going to stop, we're going to withdraw or withhold interventions, and we make sure that there's an order for no CPR. We're not going to go into how we withdraw any of this artificial life support, but what we do need to do is address those acute interventions like mechanical ventilation, tube feedings, medication, and we look at each one of them and in that balance between benefit versus burden. If the family's decided, yes, we're going to transition to comfort, each one of those interventions are looked at. Is this going to benefit the patient in terms of making him comfortable, making him or her comfortable, or is it adding a burden? And that includes any and all interventions, any and all medications as well. And some patients will even talk about those compression stockings. If you've been in the ICU or acute care settings, many of our patients don't move, so we have to put those compression stockings on. And so we even address issues like that. We do need to discuss disposition. So, many times when that decision has been made to transition to comfort, are they stable enough to leave the ICU? Are they even stable enough to leave the hospital? Many times patients or families will tell us, well, I want to take him home. And we need to ask that question, is that patient able to go home, or do we need to consider an inpatient hospice setting? And this is where we need to use our case managers or social workers a lot. They also continue some of these conversations that we have. And briefly, what I want to do is refer to some of the tools to document those conversations. I know in further sessions here, these will be discussed even more in detailed form, but for right now, we need to document, do we need to have an outside hospital DNAR form completed? It's purple in Missouri, it's yellow in Kansas. Or do we need to consider that transportable physician order for patient preferences, or that TPOPP? That's the newer form. This is all the education that we're trying to include for you here, which in essence, that TPOPP form is a physician's order, which isn't what an advance directive is, or a living will, or even a durable power of attorney for healthcare form. So the TPOPP now covers that added dimension of that physician's order, but we know that more education is needed for providers as well as patients and families. And finally, making sure that we document in the electronic medical record. I have a picture here for you of the TPOPP form. It's that bright pink picture. I'm sorry, I'm spitting on the computer here, but you can see that there's a website to go to for the practical bioethics, and you can download, the TPOPP resources. But what this form really does is address the first issue, is that cardiopulmonary resuscitation, that CPR. Does that patient want CPR or not? That's really a conversation to happen. And these conversations don't always happen in one setting. Sometimes we have to revisit because it maybe in the acute care setting, that's all we can get addressed right now is do we not want to have CPR performed on this person? Then we also look at the levels of medical interventions. Is this someone who wants to transition to comfort measures only? Or are they willing to try some limited additional interventions, maybe some IV fluids? Maybe, they're okay with coming back to the hospital and maybe some antibiotics, but not a whole lot more. Or are they someone who want full treatment that includes the ICU, going on mechanical ventilators, things like that? And then there's a separate section for addressing that medically administered nutrition. This is a big deal, folks. Nutrition is huge for a lot of people. And so we need to make sure to address that. And then finally, TPOPP has that section for documenting signatures and physician orders. And just briefly, in our O2 setting, in our electronic world, we have the ability to document, and here I'll show you, this is a mock-up of one of our advanced care planning notes, which also includes indicating what their code status is, whether we have that advanced directive or TPOPP, and then we actually have a separate note that's titled advanced care planning so that we can now sort through and find this if the patient should have subsequent conversations. Families do express concerns even after we've had those conversations, and I realize I'm running out of time, so I'll just kind of express to you that you have to be prepared for some of these questions that come up. Do something, a lot of times they're asking, especially when it feels like we might be limiting and making sure they're staying comfortable. But I'm sure you can understand that there's going to be a lot of questions that come from families even after those discussions have happened. So it is very important to have those conversations that's patient-centered. We want to know how families want their information given to them. You want to make sure you're honest with them, that you reframe and refocus as much as possible. And I'm going to skip over, but making sure body language is there. I've thrown in a slide with some helpful phrases. These have helped me immensely. And I think there's even some resources I've directed you. Ira Byock has written 2 books, The Best Care Possible, as well as another one, The 4 Things That Matter Most. If you're interested, he's a wonderful writer. He's a palliative care physician, but he's done a lot of work around working with helpful phrases for providers to help patients and families have those conversations when patients are very seriously ill. It's difficult to have these conversations. Bad news is hard to give. It's hard to bring up spiritual concerns. And then think about those patients and families who have different cultures or use a different language, or even have children. Those are all difficult conversations to have. There's some very important helpful strategies. Anytime that you can incorporate these, it really is important for you to kind of build this into your repertoire of skills as you're working with patients and families in acute care and ICU settings. And finally, just some key takeaway messages for you. It's important to have those goals of care conversations early in that hospitalization. The motto in our continuum of care department at KU is that everyone needs to have a goal for the day and a goal for the stay. It's really important that we're always continuously thinking about this. With practice, and that's what I always put that caveat, you have to practice. We're not innately born with good communication skills or the ability to be excellent communicators. We have to practice, but we can listen and we can contribute to those goals of care discussions. It's important to arrive at consensus, and as you can see, my bias came through in this entire session, is that everyone can utilize those primary palliative care principles and everyone can incorporate them. I thank you for your attention. I know we ran out of time, but if we have any questions.
So we've got a couple questions. One of them looks like it might have been from the previous section and rolled in a little bit after we started. It's, does the provider have to engage the patient or family for the full 30 minutes in order to meet eligibility for billing?
Yes.
I believe the answer is yes. In order, and it has to be documented as such, yes.
Okay.
Yes.
And then we've got one other one that's, can a patient ever verbally override their own post form, or would a new one need to be created? For example, if a patient has a post form that says full code, but they decide they want to be DNR or vice versa, my thought would be that a professional needs to follow the signed documented post.
That's an excellent question, and I'm sure we're going to have more from that as education gets out to patients and families. But again, and John, you may want to weigh in, if that patient has capacity and everyone determines that or understands that, and you know that patient understands and is saying that, absolutely. This is a very patient-centered form. It's a very patient-centered kind of care that we want to deliver. And if that patient, 2 weeks ago said, yes, I want everything done, but today, because of things that happen, makes a different decision, absolutely, that patient is the one to make that change.
Yeah, I also want to comment that there is a presumption that this is a dynamic document. This is not a one and out. So there's a requirement that anytime there is a change in the location of the patient, or anytime there's a major event that occurs in the patient's life, the form must be reviewed and reconfirmed or changed and modified to represent the changes. So this is not like you fill out an advanced care planning document and name your agent 15 years ago and it lasts you the next 15 years. This dynamic document is intended to be changed over time. So yes, the answer is definitely anytime there is a change in the preferences of the patient, anytime there's a change in the medical condition, anytime there is a change in the location, the assumption is that the TPOPP document is reviewed and reflects any changes in the patient's condition in terms of how to move forward with the care plan. So there is an assumption that you're going to change that document over time, and the new date is the indication in terms of how it should be going forward.
All right, and we got one more comment that rolled in that says, let's see, to bill for ACP, it needs to be at least 16 minutes, but doesn't need to be the full 30, according to CPT code 99497.
Oh, maybe somebody knows something better than we do. I thought it had to be.
Why don't we'll get back to you. We're going to have another session in mid-December, which will kind of pick up on more of the physician issues related to the Ariadne lab model in Harvard University's program that Dr. Karen Porter-Williamson will do, and we'll make sure we get that information out. We'll go ahead and provide an email to everybody today to confirm the actual payment requirements in terms of the time frame, the 16 minutes versus the 30 versus the full hour. So we'll go ahead and provide that to everybody who is registered for today's call. So thank you for that correction.
All right, and that's all I've got right now, unless anyone else wants to jump in before we sign off.
The only thing I want to remind everybody, we will send out additional information regarding the presentation in mid-December, which will focus more on kind of some of the follow-up issues that Maria just talked about in terms of how the physician engages in that conversation with patients related to serious illness care planning. And it'll be more from the medical perspective than from the nursing perspective in those situations. But Dr. Carney Williamson will be presenting the work that she went through, her 2.5-day workshop that she did with Ariadne Labs in Boston earlier this year. So we look forward to having her. There are a number of instruments and suggestions and questions that are similar to what Maria and Carol presented today. So I really encourage you to participate in that seminar as well. We'll be getting word out on the details of that probably within the next week or so. So again, thank you very much for joining us, and we look forward to having you participate in future seminars and workshops. Thank you.
And I would just urge everyone to like and follow us on Facebook, and sign up for our newsletter if you're interested in hearing about more of these kinds of events. That can be done at our website. It's practicalbioethics.org.
And Matthew, can you know when these documents will be, or these 3 hours will be posted?
Hopefully by the end of the week. That's what I'm planning.
All right, very good. And how will they get notified? Will they get an email or?
Those, I can send out an email to the people who registered for the webinar. If you subscribe to our YouTube channel, you'll get notifications when new videos go up. So that's another way to hear about our content coming out. So
actually more reliable than remembering to send out an email. So if you get on our website and sign up for the YouTube videos, that would be great.
All right, sounds good. Yep.
Thank you. Okay, thank you very much. You guys did great.